Urgent warning for seniors. 9 medications linked to rapid dementia. One person every 66 seconds in the United States is diagnosed with dementia, and emerging evidence suggests that some routine, widely used drugs may speed that decline in people already at risk. What if the pills in your medicine cabinet meant to help sleep, calm anxiety, or ease bladder symptoms are also quietly worsening memory and thinking? That's what I want to talk about with you now. I'm Dr. Blake Harrison. I work with older adults every day, and I've seen otherwise sharp, engaged seniors enter clinic visits confused, slowed, or suddenly different in ways that family members describe as not like them. Often the first place I look is the medication list, including over-the-counter drugs. Today I'm laying out 9 medication categories that have been linked in peer-reviewed studies to accelerated cognitive decline or higher dementia risk. For each one, I'll tell you what it's commonly used for, how it can affect the brain, which studies have raised concerns and when, what signs to watch for, and what safer options you can discuss with your prescriber. This is urgent, but it's not hopeless. Many changes are reversible or at least slowable when identified early. But you must act with your clinician, not on your own. Before we go on, I want to hear from you. Comment below which medications you take and whether you've noticed brain fog. That single step helps us understand who needs this information most. A quick primer on mechanisms, so the rest of this makes sense. 3 pathways show up repeatedly across these studies. First, anticholinergic activity. Drugs that block acetylcholine, a neurotransmitter crucial for attention, memory, and learning, can impair cognition. When several anticholinergic medicines stack up, their effects add. Clinicians call this anticholinergic burden. Second, interference with nutrient absorption, especially vitamin B12, can produce cognitive symptoms that mimic dementia. Proton pump inhibitors and some other drugs are implicated here. Third, drugs that alter brain chemistry broadly, for example, by increasing GABAergic activity or suppressing dopamine, can blunt cognition, slow processing speed, and mask or accelerate underlying neurodegenerative processes. Studies range from observational epidemiology to large cohort analyses. When I quote a finding, I'll name the year and the journal so you can follow up if you wish. Always remember, these studies mostly show associations. They're powerful warning signs, but they aren't neat proof of causation in every individual. We'll count down from number 9 to the most important item at number 1. Keep in mind, if you take more than one drug with anticholinergic effects, your risk adds up. So pay close attention as we go. Number 9, diphenhydramine, most commonly known by the brand Benadryl, a sleep aid and allergy medication available over the counter. Many seniors reach for it to treat itchy eyes, runny nose, or occasional insomnia because it's cheap and familiar. Mechanistically, diphenhydramine is a potent anticholinergic. It crosses the blood-brain barrier and blocks acetylcholine, the messenger that helps the brain form new memories and pay attention. A 2023 study reported in a geriatrics-focused journal found an approximate 54% higher dementia risk associated with diphenhydramine use among older adults in their analysis. That's a relative increase, meaning compared with similar people not exposed, and the study's controlled for many factors, but they can't prove individual causation. Watch for signs like increased daytime sleepiness, trouble finding words that used to come easily, or worsening short-term memory. Safer options to discuss with your clinician include second-generation antihistamines that do not cross into the brain, such as loratadine for allergy relief, and behavioral sleep strategies, or melatonin for occasional insomnia. Do not stop prescribed medications abruptly. Bring the medication to your next appointment and ask whether an alternative is appropriate. Number 8. Proton pump inhibitors, drugs like omeprazole, Prilosec, and esomeprazole, Nexium, widely prescribed for reflux, ulcer prevention, and chronic indigestion. PPIs reduce acid production, which helps many patients, but long-term suppression of stomach acid can impair absorption of nutrients, notably vitamin B12 and magnesium, both important for nerve function and cognition. A 2016 analysis published in JAMA Neurology observed about a 44% increased dementia risk in an older population taking prolonged PPI therapy. That association prompted follow-up studies and debate. Some later analyses show smaller effects, but the concern is real enough to warrant review, especially in patients on long-term PPI therapy without a clear ongoing indication. Look for subtle signs, new forgetfulness, slowed thinking, or difficulty with balance that can be tied to low B12. Practical steps include asking your prescriber whether you still need continuous PPI therapy, whether a trial of step-down therapy or an H2 blocker like famotidine is reasonable, and whether testing for B12 and magnesium levels is appropriate before starting or stopping supplements. Number 7. Oxybutynin and other bladder antimuscarinics prescribed for urinary urgency and overactive bladder. This class includes oxybutynin in both pill and patch forms, and is very commonly used in older adults who are bothered by urgency or nocturia. Many antimuscarinics cross into the central nervous system and have strong anticholinergic properties. Oxybutynin in particular is known for its central penetration. A 2019 analysis in BMJ linked these agents to roughly a 49% higher dementia risk in people over 65. The mechanism is straightforward. Blocking muscarinic acetylcholine receptors alters memory circuits. Watch for increased confusion, withdrawal from social activities, because the person is worried about accidents or sudden changes in mood. Non-anticholinergic alternatives to discuss include mirabegron, pelvic floor therapy, timed voiding, and referral to a urology specialist. All medication switches should be managed with a clinician. Don't stop a bladder drug suddenly and risk complications. Number 6. Statins, the cholesterol-lowering medicines many of you take to reduce heart attack and stroke risk. Simvastatin, atorvastatin and others. Statins are heterogeneous. Some cross the blood-brain barrier more than others. Cholesterol plays a role in myelin and neuronal membrane health, and long-term, aggressive cholesterol lowering could theoretically alter neural support in susceptible older adults. A 2023 study in Frontiers in Aging Neuroscience reported a 26% higher risk of mild cognitive impairment among people over 70 on long-term statin therapy in their cohort analysis. This does not mean everyone on a statin will develop problems, nor does it negate cardiovascular benefits for many patients. Instead, it suggests clinicians and patients should weigh risks and benefits individually, especially for primary prevention in advanced age. If you or a loved one has new cognitive symptoms, ask whether the specific statin, its dose, or whether a trial period off medication under supervision is reasonable. In some cases, switching to a statin with less central nervous system penetration or reviewing the overall cardiovascular risk strategy is an option your clinician can explore. Number 5, benzodiazepines, the class that includes lorazepam, Ativan, diazepam, Valium, and alprazolam, Xanax, commonly prescribed for anxiety, insomnia, and sometimes agitation. These medications enhance GABAergic signaling, which is calming but also slows neural processing. A 2022 study published in BMJ found an association between benzodiazepine use longer than 3 months and about a 51% higher risk of Alzheimer's disease in older adults. Clinically, benzodiazepines can cause daytime sedation, falls, and memory problems that family members often interpret as aging. Alternatives to discuss include cognitive behavioral therapy for insomnia or anxiety, SSRIs or buspirone for generalized anxiety disorder, and careful tapering strategies planned with a clinician, to reduce withdrawal risk. If benzodiazepines are necessary for severe symptoms, the general principle is to use the lowest effective dose for the shortest possible time under medical supervision. Number 4. Amitriptyline, historically known as Elavil, is a tricyclic antidepressant still widely used off-label for chronic pain, neuropathy, and insomnia at low doses. Amitriptyline is among the most anticholinergic drugs commonly prescribed. That means it blocks acetylcholine strongly and can have pronounced cognitive side effects. In a large analysis reported in JAMA Internal Medicine in 2015, long-term exposure to tricyclics like amitriptyline was associated with about a 54% increased dementia risk. Practically, patients sometimes start amitriptyline for back pain or sleep and persist for months to years because the low dose seems to help pain. But the cognitive toll can be substantial: memory lapses, slower thinking, increased confusion, and personality blunting. Safer options to raise with your prescriber include duloxetine for neuropathic pain, gabapentin where appropriate, non-pharmacologic pain strategies, or considering low-dose doxepin only after careful review, always weighing benefits, side effects, and the patient's cognitive baseline. Don't skip number 3. This one is commonly prescribed for depression and is often assumed safe. Number 3. Paroxetine, commonly sold as Paxil, an SSRI antidepressant that also has notable anticholinergic activity compared with other drugs in its class. While SSRIs are generally first-line and safer for many older adults, paroxetine's anticholinergic profile has raised concern. A 2021 report in Frontiers in Psychiatry connected paroxetine use with cognitive decline within a year in older adults in their observational sample. That doesn't mean paroxetine will harm everyone, but it does mean prescribers should preferentially consider SSRIs with lower anticholinergic effects, such as sertraline or escitalopram, particularly in older patients with cognitive complaints or multiple competing medications. Monitor for new memory problems, a blunting of effect or difficulty concentrating after starting or increasing paroxetine. Number 2, antipsychotics, medications like quetiapine, Seroquel, risperidone, and olanzapine, sometimes used off-label in older adults for agitation, insomnia, or behavioral symptoms. These drugs can suppress dopamine and other pathways that contribute to cognition and alertness. A 2022 analysis in the Lancet Healthy Longevity reported a striking association: a 71% higher rate of accelerated cognitive decline over 1 year in older adults exposed to antipsychotics in certain settings. In addition, antipsychotics carry known increased risks of stroke and mortality in older adults with dementia. That's why major guidelines strongly recommend non-pharmacologic approaches first. Behavioral interventions, environmental changes, sleep hygiene, caregiver support, and treating underlying causes such as pain or urinary infection. When antipsychotics are unavoidable for severe symptoms, they should be used at the lowest effective dose for the shortest duration, under close monitoring and with a clear plan for reassessment and discontinuation. And number 1, the single most important concept to understand: anticholinergic polypharmacy, or cumulative anticholinergic burden. This isn't one medication, but the stacking of multiple drugs that each have some anticholinergic effect. Studies in Age and Aging in 2022 showed that people in the highest anticholinergic burden group had roughly 120% higher dementia risk compared with those with minimal burden. That's more than double the risk, and it's cumulative. Even small contributions from an over-the-counter sleep aid, a tricyclic antidepressant, and a bladder drug can add up to a clinically meaningful problem. Clinically, anticholinergic burden often presents as gradual decline, fluctuating attention, increased daytime sleepiness, or a sudden step down in function when a new drug is added. The good news is this is one of the most modifiable risk factors. A focused medication review, deprescribing where appropriate, and substituting non-anticholinergic alternatives can lead to measurable improvements in alertness and memory in many patients, particularly when done early. Let me give you two clinical vignettes that illustrate what I see in practice. The first is a composite anonymized case to protect privacy. Mrs. L is 78, living independently, and had been taking diphenhydramine nightly for years to help her sleep, while also being on a low-dose tricyclic for chronic back pain and an anti-muscarinic for bladder urgency. Her daughter called, alarmed by increasing forgetfulness and daytime napping. After a medication review with her primary care doctor and pharmacist, diphenhydramine was switched to loratadine for allergies, and non-pharmacologic sleep measures were implemented. The tricyclic was tapered and replaced with a different pain strategy. Within weeks, Mrs. L was clearer during conversations, less drowsy, and able to resume driving safely under close reassessment. This does not guarantee the same outcome for everyone, but it shows how a structured review can produce rapid, meaningful change. The second vignette is representative of a nursing home scenario. Mr. S, age 84, was started on a low dose of quetiapine for nighttime agitation and was already on a PPI and a benzodiazepine. Over 6 months, his family and staff noted marked decline in engagement, difficulty following conversation, and new falls. A geriatric consult prompted a stepwise taper of the antipsychotic and benzodiazepine, active management of reflux without continuous PPI, and aggressive non-pharmacologic behavioral strategies. Over the next months, he regained some function and his falls decreased. Again, these are composite examples, but they reflect the reversibility potential reported in multiple clinical series when medication burden is addressed promptly. So what should you do right now? First, do not stop any medication on your own. Sudden discontinuation can be harmful. Instead, schedule a focused medication review with your primary care clinician and ask for a pharmacist-led reconciliation if possible. Bring every medication to the visit, prescription pills, over-the-counter products like sleep aids and antacids, and any vitamins or herbal supplements. A pharmacist can compute your anticholinergic burden and point out cumulative risks you may not realize exist. Second, ask specific, actionable questions at your appointment. Questions to consider. Which of these medicines are still needed now? Are there safer alternatives with less cognitive risk for my age? If a drug is contributing to my memory problems, what is a safe plan to taper it? Would it make sense to test my B12 level before starting any supplements? Can we involve a pharmacist or a geriatrician in this review? These questions are short, practical, and put the emphasis on shared decision-making. Third, watch for signs to report back to your clinician. Early warning signs include new or worsening short-term memory lapses, increasing brain fog or confusion, personality changes such as apathy or withdrawal, difficulty following conversations or multi-step tasks, and sudden or rapid decline in function after a medication change. If you notice falls, increased daytime sleepiness, or a return to behaviors that are uncharacteristic, bring those up immediately. Fourth, discuss specific alternatives rather than simply stopping a drug. For example, for allergies or occasional insomnia, ask about loratadine instead of diphenhydramine and behavioral sleep interventions before starting sedatives. For reflux, ask whether you need continued PPI therapy and whether famotidine or lifestyle measures could be appropriate. For bladder urgency, discuss mirabegron and pelvic floor therapy. For depression, ask whether sertraline or escitalopram would be safer than paroxetine. For anxiety and sleep, consider CBT and medications like buspirone rather than long-term benzodiazepines. For chronic pain, discuss duloxetine or gabapentin where appropriate, as well as non-pharmacologic approaches. For cholesterol management, Review the indication for statins in the context of age and overall cardiovascular risk with your clinician. Every alternative should be individualized and supervised. Fifth, ask about tests that can clarify reversible contributors. Vitamin B12 level testing is reasonable when cognitive symptoms are present, and especially if you are on a PPI. A medication reconciliation combined with cognitive screening can help distinguish medication-related problems from progressive neurodegenerative disease. If your clinician is uncertain, ask for a geriatric assessment or referral to a memory clinic. I want to stress one more time the medico-legal and clinical cautions. The studies I referenced show associations reported in journals like JAMA Neurology, 2016, BMJ, 2019 and 2022, JAMA Internal Medicine, 2015, Frontiers in Psychiatry, 2021, Frontiers in Aging Neuroscience, 2023, Age and Aging, 2022, The Lancet Healthy Longevity, 2022, and other peer-reviewed analyses. They raise real concerns and they guide prudent clinical practice, but they do not mean every person who ever takes one of these drugs will develop dementia. What they do mean is that medication use is a modifiable risk factor. By working with your prescriber and pharmacist, you can often reduce unnecessary exposures and potentially improve or stabilize cognition. Practical checklist for your next visit. Bring every pill bottle and supplement to the appointment. Ask your clinician to compute your anticholinergic burden and review the necessity of each drug. Request B12 testing if you are on long-term PPIs or have suggestive symptoms. Ask about non-pharmacologic approaches first for sleep, anxiety, and behavioral symptoms. And if a medication change is advised, get a clear clinician-supervised taper plan rather than stopping abruptly. If you're a caregiver or adult child watching this, you can help by compiling a medication list, noting when symptoms began or worsened relative to medication changes, and advocating for a pharmacist review. Clinicians, please prioritize medication reconciliation and deprescribing conversations, especially for patients with early cognitive complaints or multiple anticholinergic exposures. Before I close, a couple of final points to keep this calm but urgent. First, action matters. Many patients show measurable improvement in alertness and daily functioning after a careful medication review and supervised deprescribing. Second, this is part of a larger picture, lifestyle measures. Good sleep, steady physical activity, cognitive engagement, social connection, blood pressure control, and nutrition also matter for brain health and can complement medication changes. Third, these conversations are not about blame. They're about reassessing risk in light of new evidence and making informed choices together. Now do one concrete thing. Schedule a medication review with your doctor or pharmacist this week. Bring every pill bottle, prescription and over-the-counter, and a brief note about any memory or thinking changes you or a loved one have noticed. If you found this video helpful, share it with a senior you love or with a caregiver who can help make that appointment. I'm Dr. Blake Harrison. This is an urgent warning but also a practical one. Medications matter for the brain. With careful review and teamwork, you can reduce unnecessary risks and protect what matters most, your mind and your life.